role of PET CT in this situation. We now come to our last topic, which I think is also becoming extremely important. In the era of personalized medicine, precision medicine becomes extremely important. We can now target our therapies in the patient based on individual patient responses. And to talk to this, we have with us Dr. Kalyan. Dr. Kalyan did his internal medicine in US and then subsequently specialized in genetic medicine at the Stanford. He runs this K&H unit and also is associated with AAG, personalized medicine department. He'll talk to us on molecular testing for precision medicine in colorectal cancer. Kalyan.
Thank you very much, sir, and thank you, Dr. Nagesh Reddy garu and Dr. Jawahar garu for inviting me to. Actually, the topic that we are discussing is of utmost importance given the time and given the condition. So let me briefly go in on the relevance of this topic. So this is, as per WHO, the worldwide cases of cancers. And if you see colorectal, it is around 20 lakh people at this time are having colorectal cancers. This is worldwide. But if you come to India, this is Asia and India. If you can see, half of the world population in colorectal cancer are from India in 2020. And if you see, compare from the backslider now, the liver, the esophagus, the stomach, it is on rise. This is because there is some lack of awareness in terms of screening and in terms of currently available practices, be it epigenetics, be it dietary changes. All these have very significant impact. So coming to the main point, the colorectal cancer. As my learned colleague already explained, most of them are sporadic, which means you are not born with them. It happens because of epigenetic factors. And only about less than maybe 3% are truly inherited, which are present in the germline, and most of them are sporadic. So these are the genes that we check, and this has been extensively discussed so far. So I will go towards what is this personalized medicine about, and how did it start, and where we are right now. So historically, the first one, when we are doing medicine, there were no targeted therapies, there were no genomics, or all we know is genetics or Mendelian. So the first medication that they found was tamoxifen. It is a targeted therapy. So it has a tremendous impact on treatment of breast cancer at the time. And in 1982, they started, okay, now we have the oncogenes developed. Oncogene is nothing but these are the genes which we identified that these are the genes which have any kind of mutation will develop into a cancer at a later stage. And going forward, extensive research has been done, and the first medication, which is targeted therapy, which is curative for cancer, came in the form of imatinib. So the lifespan of all CML patients improved tremendously. So at the time, so sequencing was very expensive business, and it was not available for a patient at the time. It was only for research. So the breakthrough technology, which is right now what we are using, is called NGS technology, next generation sequencing. It started in 2005. And since then, the sequencing became very easy, and there were all the tumors are being sequenced. And since then, a lot of research went into what is it, why people are developing cancers kind of thing, and what are the main pathways which are drivers to have this developing of cancers. So from here, multiple pathways, EGFR pathway, vestibular growth factors pathway, KRAS pathway, BRAF, all the medicines that we are targeted are started after the invent of NGS. So coming to the molecular testing for cancers. So right now, the initial path breakers are called, the company called Foundation One. What they did was they gathered these tumor samples, and then they said, okay, let us do DNA sequencing. And since 2011, they've been working on extensively. They went to clinical trials. They associated with the multiple institutions, and then they did sequencing of all these tumors. And in 2017, FDA approved, okay, Foundation One, you can develop as a test for all solid tumors, where you can do sequencing and give what are the targeted treatments available. And in 2014, the same thing, Memorial Sloan Kettering Hospital they started developing a huge database. Fortunately, I'm part of developing that database back in the day. So right now, they are also having FDA approval to do multiple sequencing patterns, and Right now, there are almost for colorectal cancer, this is the timeline. So the first medication which was approved was called cetuximab in 2004. It is an anti-EGFR agent, and this became really standard of care at the time. Every colorectal cancer which is stage 3 and stage 4, we're getting these medications. But in 2018, they figured out, okay, cetuximab is not working on everybody. We need to look for KRAS mutation. So if you have only wild type, which means there is no mutation in the KRAS gene, especially in chromosome 2, codon 13 and 12 and 13, then only cetuximab will work. And then there are multiple medications which started. But all these medications, they cannot be given blindly. We need to look for what is the mutation present and why do we need to get it tested. In the last 3 years, it is almost all the medications are immunotherapies which have been approved, and they are doing a tremendous job. So the lifespan for even stage 4 colorectal cancer is improved tremendously, but still the main goal of the topic here is if you have colorectal cancer in stage 1, you can have a curative surgery. All this molecular testing and a lot of imaging will happen only in stage 3 and stage 4, or if you need chemo, or if you need adjuvant radiation therapy. But having a colorectal cancer, it can be prevented and it can be identified at an earlier stage, and you can have a curative treatment, which is surgery. And these are the 4 tests which are approved by FDA, which are available at this time for all solid tumors. The first one is Foundation 1, the second one is MSK Impact. So if you look at the number of genes assessed, there it differs between each and every company. The reason is all these genes which we are assessing, even though there are no targeted therapies, all these genes are proven oncogenes. I will come back at the later point why testing for all these things are important. But we can identify copy number variations, gene fusions, MSI, TMB, except for PDL1, most of the testing can be done by gene sequencing. Usually we do it at a depth of 1000x so that we will not miss any areas which are of important. So these are the biomarkers that we are right now looking at colon cancer, especially KRAS, which is wild type, so that you can get cetuximab therapy, and other biomarkers as the previous speakers mentioned. All MSI markers are of utmost importance, and everybody has to be checked for this one. It can be done through PCR model, IHC model, but NGS is not inferior to those testings. And BRAF, which you can get in targeted therapy, which significantly improves. But the problem here, what happens is, as Dr. Ravikant mentioned before, we do not know what is the MAF. MAF is mean allele frequency in Indian population, because we don't have that data. What we have is what is the frequency of these mutations in Caucasian populations, in African American populations, in Japanese population, in Chinese population, but we don't have anything. We are pulled into a group of South Asian population. How many Indians are there? We do not know. That is where the genome AD represents. So we need to develop this kind of a database where we will know how many of these mutations which have targeted therapy, and how common is it in Indian population. And this is NCCN recommended therapy, and I am not talking about the regular conventional chemotherapy. This is only targeted therapy. So the first thing we look for is that the patient is wild type or mutant for KRAS, and if this is mutant, then we will directly go for MSI stable, and then we either look for bevacizumab or anti-PDL depending on the testing. And for wild type, we look for left or right column. This is the NCCN guideline, and these are the pathways which are potential for targeted therapy for now in colorectal cancer. And there are medicines already available in the market for EGFR, VEGF, and some of the Notch proteins, and also other immune checkpoint mediators. So if you look at this, it is a little bit small, but the drugs in pipeline, it is enormous, especially in phase 1, 2, and 3. So table 2 indicates these are all the trials available across the globe which are developing targeted agents for EGFR. Most likely within the next 4 or 5 years, almost half of these medications are coming into market. And table 4 is anti-angiogenic agents, which is mostly EGF inhibitor. And if you count the number, there are more than 380 phase 2, phase 3 trials which are currently on trial, and most likely the success rate will be around 20 to 30% that they will hit the market. And the next one is HGF MET. Again, multiple trials are going on, and other novel agents which are mostly immunotherapies. And this is immune checkpoint modulators. So if you look at all these medications, there are more than 390 phase 2, phase 3 trials happening across the globe, which are developing targeted therapies, which are going to be either first line or second line chemotherapy options for metastatic colorectal cancers. And coming to our experience, so we did a sequencing greenhouse, and we use MSK Impact database for our analysis and algorithms. So if you look at number first chart, SNV file for novel mutations. So for each cancer, each tumor, we do 380 genes at a very deep depth. And what we find is, if you look at the number of mutations we find in each cancer, there are around 21,000. But out of these 21,000, in only 8,000 are documented, which means if you look at the third graph, there is an RS number. So if there is RS number, which means it is documented that this has some significance and it is documented in the global database. Everything which is novel, we do not know what it means and how common it is in our population and what is the significance of it, we do not know. So almost we only know about 1/3 of the changes in our genome in a tissue of colon cancer that we can have an clinical report on them, but remaining things are all novel. So coming to the second paragraph, it is all copy number variants, which is either insertions or deletions, which have more significant impact. Even in this one, there are almost 353, and these both files belong to the same patient, and this patient is stage 4 colorectal cancer. And this patient has almost 353 copy number variants, including insertions and deletions, and out of which we know the function of only 113. So we only scratched the surface when it comes to molecular pathology and molecular genetics. But this is about high time that we need to start doing more sequencing of our tumor samples, and then we need to have an collaborative effort right from the medical oncologist, surgical oncologist, and pathology department, and everybody to work together to see how we can really decipher what is the tumor causing mutation, why the incidence compared to 30 years back is significantly increased, especially in Indian population. And is it that we are finding out more, or is it because we are having more cancers that need to be answered as well? And coming to GI tract, not only just colorectal cancers, we are seeing as the previous mention was saying 37-year-old with stage 4 rectal cancer, 28-year-old with stage 4 rectal cancer. This was uncommon some 30 years back. What are those epigenetic changes which are impacting this the high incidence of these colon cancers? And as we know already that most of these are sporadic. So it is about high time that we need to have molecular testing of most of these tumor cancer cells. And I think we are beyond time. So I will conclude here, and once again, thanks for the opportunity, Dr. Nageshwar Reddy garu and Dr. G.V. Rao garu, and thank you so much.
Thank you, Kalyan. I think precision medicine is going to be the next thing in treating many of our cancers, and colorectal cancers are no exception. Thank you for taking us through all this data and also the uncertainties in this area. Most important, I think we require to generate our own data because of the marked variation that we have seen from the first presentation that Ravikant gave us. So we have to develop our own data. I think this will become the cornerstone of treatment of many of these patients. As we come to the end of the session, I'd like to thank all of you for listening to this. I'm sure all of us had a very educative session. We'll continue with this series, and tomorrow we'll meet again on therapies of endoscopic therapies in patients for colorectal cancer, both the early stages and late stages. Hope to see you again tomorrow.